Good afternoon, and thank you for joining us for New Start Foundation's Virtual Addiction and Mental Health webinar, Current and Novel Approaches to Opioid Use Disorder, a medical module for physicians and non-physicians with Dr. Jennifer Wyman. Dr. Wyman is currently an assistant professor in the Department of Family and Community Medicine at the University of Toronto, and associate medical director of the Substance Use Service at Women's College Hospital in Toronto. Ladies and gentlemen, please welcome Dr. Jennifer Wyman.
Good afternoon or good day, everybody. Thank you so much for joining me today. I appreciate the opportunity to talk to you about new opportunities with respect to medical therapy for opioid use disorder. We're going to start with just reviewing some of the learning outcomes, some disclosures. We'll do a little bit of question and polling to get started, and then we'll jump in. So I'm hoping at the end of this session, you'll have a clear understanding of the role of medication-assisted therapy in the treatment of opioid use disorder, a little bit of a better sense of the roles of methadone, buprenorphine, some of the newer buprenorphine formulations, as well as long-acting morphine. Consider where opioid agonist therapy sits along the continuum of harm reduction and treatment options. And lastly, I'm hoping we have a little bit of time just to touch on the overlap between mental health disorders and opioid use disorders and the importance of treating both concurrently. So with respect to my disclosures, as you may know, I'm the Associate Medical Director of the Substance Use Service at Women's College and the Medical Educator with Medify. I was the academic lead for the Opioids Clinical Primer, which is an online course that was funded by the Ministry of Health to help clinicians develop core skills in managing opioid issues related to both chronic pain and opioid use disorder. And I was the clinical lead on the opioid use disorder tool developed by the Center for Effective Practice. I'm not receiving an honorarium for this talk, and I'm not endorsing any specific group of clinics, pharmacies, or providers with respect to medication treatment. So with no further ado, let's pose some questions just to sort of get people thinking, and hopefully those get answered as we go along. So the first question I'd like you to think about is essentially a true or false. Buprenorphine, naloxone, and methadone are both first-line treatments for opioid use disorder. True or false? And I can't see any answers to the question. So what I'll do is I'll just continue to read them aloud, and then we'll be taking up the answers as we go. The second question, this is a sort of brain teaser for many people. The naloxone in sublingual buprenorphine naloxone is included to A, deter people from using opioids by blocking their effect, B, deter people from injecting their buprenorphine naloxone, C, reduce the risk of overdose with buprenorphine, or D, prevent a high from buprenorphine. Perhaps what I'll do is just make sure that we come back to these questions at the very end if we have some time to make sure that the answers are clear. Question 3, buprenorphine naloxone should only be prescribed by clinicians who also prescribe methadone. True or false? Question 4, advantages of buprenorphine over methadone include which of the following? Less sedation, lower rates of overdose, fewer drug interactions, more flexible take-home dosing, all of the above. And finally, in patients with substance use disorders, treatment of anxiety and mood disorders cannot be undertaken until the substance use disorder is in remission. True or false? I think you already know my bias on that one, which is false. So let's move on to our slides. And the first slide is a summary of the CRISM recommendations for the clinical management of opioid use disorder. CRISM, for those who may not be aware, is the Center for Research into Substance Misuse, which is an arm of CIHR. the Canada Institute for Health Research. And these guidelines were developed by a panel representing scientists and clinicians from across Canada, intended to develop national guidelines with respect to general approaches to managing substance use disorders. Their role is not to get into the nitty-gritty of dosing and dose adjustments, but to prevent the high-level overview of what constitutes appropriate treatment for people with opioid use disorder. And essentially what we're going to do over the next while is really unpack this slide. But there are a few things that I want to draw your attention to, especially given the fact that we're focusing so much on medication therapy today. One is the emphasis on incorporating psychosocial interventions across the spectrum of care. And that really emphasizes incorporating rather than siloing people either into psychosocial treatment or into medication treatment. CRISM recommends that psychosocial interventions be offered routinely in conjunction with pharmacologic, but not be a required element in order for people to access medication and therapy. The other thing that I think is really core to identify in this slide is the recognition that people can move along a continuum in terms of the intensity of their substance use, and treatment intensity really needs to mirror that. So when people are perhaps using more intensely, and more intensely means using higher risk substances, such as fentanyl, or using in more intense and high risk ways, such as injecting, then they need more intensive interventions. People who are using in less risky ways, for example, pharmaceutical opioids and taking them orally only, may need or be able to benefit from less intensive approaches. But people move along that continuum over time. And so care really needs to be reevaluated and readjusted with the goal, obviously, of helping people to stabilize and achieve their own goals overall. And I think part of that is recognizing that across the continuum, we should be talking about harm reduction. And that includes everything from naloxone kits to offering safer supplies for people who are using in higher risk ways. And that sometimes interventions that may be focused on harm reduction can help to engage people in what will become treatment, and we should not divide those, I think, too rigidly into particularly into silos of either harm reduction or treatment. I think opioid agonist therapy is a perfect example of an intervention that actually meets both of those requirements. So looking at the next slide in terms of CRISM and their recommendation about medication, the recommendation is pretty strong that, first of all, opioid agonist therapy is really first-line treatment, and that when possible, first-line therapy should be buprenorphine naloxone. And the reasons for that we'll talk about in a bit more detail, but it really has to do with the reduced risks associated with buprenorphine relative to methadone, and the improved flexibility with respect to take-home dosing and pharmacy dosing. For those who don't do well with buprenorphine, and certainly there are people, as much as I am a fan and have seen many great results with buprenorphine, then we should consider transition to methadone. Or we could start methadone in people who strongly prefer it, either because of past experiences or the ways in which they're using. And then finally, third-line treatment, which is not familiar to many people, but we're seeing more of, especially in light of fentanyl use currently, is slow-release oral morphine, also called Cadian. So why does CRISM not recommend withdrawal management as a primary treatment? In fact, they recommend fairly strongly against treatments that focus only on withdrawal management. And that's because of the high risks of relapse when people are detoxified and not engaged in a further kind of treatment program. Tolerance to opioids can decrease very quickly within 3 to 5 days. And for people who are released from detox management or from a residential treatment and who go back to using, because of their loss of tolerance, they're actually at very high risk of relapse. And it's an evidence-based recommendation that informs us that people who are maintained on opioid agonist therapy have lower rates of relapse and lower rates of overdose. What CRISM does recommend is that people who choose, in conjunction with their care providers, to pursue withdrawal management, pursue a slow, supervised withdrawal. That's more likely to be safely managed and perhaps to reduce the risk of relapse when withdrawal symptoms are quite intense. And that following withdrawal management, people be connected to longer-term addiction care, which could be residential programs, psychosocial programs, or other forms of support, including harm reduction services, low barrier housing, and peer support. I will mention naloxone a few times because I think it's so crucial. So people who stop opioid use, whether in a detox setting, residential treatment, or on their own, are at high risk of resuming using an overdose and should be counseled on their loss of tolerance and provided with take-home naloxone and taught how to use it. With respect to psychosocial treatment, I really touched on this previously. The CRISM recommendations are that psychosocial treatment interventions be offered across the spectrum of care and regardless of whether people are engaged in opioid agonist therapy, but people should not be required to participate in counseling or attend a certain number of sessions as a condition of receiving OAT, which has at times been done in the past and been a barrier to accessing care. So in terms of the current overdose crisis, I think we've all been quite consumed by COVID over the last 6 months, understandably. But those of us who work in the area of addictions, I think, are really feeling the burden of these dual crises because the overdose crisis hasn't gone away. We've been dealing with it for the last 5 years. And it's really related to very complex overlapping challenges, some of which go back to opioid overprescribing 10 and 15 years ago, some of which go back to the changes in the street supply of opioids currently. And in light of COVID over the last few months, further changes which have really put people who use substances at risk, and that relates to changes in the supply, so that the supply of drugs on the street is ever more toxic and involves all kinds of mixes of fentanyl analogs, and illicit benzodiazepines. And then reduction in harm reduction services, such as safe consumption sites, which have, and recommendations that people physically distance. And that isolation has been hugely problematic for people who have been using alone and therefore at increased risk of overdose. So the next slide, I think, speaks a little bit more graphically to what's been going on with respect to opioid-related deaths and fentanyl. And the key takeaway here is that fentanyl or fentanyl analogs are being found in almost 80% of opioid-related overdose deaths. And almost 80% of people using street opioids have fentanyl found in their urine screens, even if they did not think that they were using fentanyl. So there are those who obviously know that they're using, and I just want to say that using fentanyl doesn't always mean injecting. There are people who snort and smoke fentanyl. But even beyond people who are knowingly using fentanyl powders, those who are thinking that they're buying heroin, and even those who are thinking that they're buying pharmaceutical opioids in pill form, are at risk of being exposed to fentanyl powders in these compounds. And because of the tremendous strength of fentanyl powder, this poses a huge risk of overdose, especially when fentanyl is also being co-mixed with benzodiazepines. So I don't want to focus too much on sort of hardcore research, but the next slide I think is important in reminding us about, again, where harm reduction and treatment intersect. And this is the report of a study that used modeling to calculate how many overall overdose deaths were averted by a combination of take-home naloxone, which we might consider harm reduction, overdose prevention services, I think, which most people would consider harm reduction, and opioid agonist therapy, which most people consider treatment. But individually, each of those made a significant impact with respect to reducing overdose deaths, and in combination, they may have averted more overdose deaths than actually occurred in British Columbia. So this really speaks to the balance of, as I said, harm reduction and treatment interventions, and the need to really be familiar with what's happening out there on the streets and what we can do to be preventing some of the harms associated. I'll touch on naloxone again. I would hope that most people are really familiar with it at this point. But with respect to its mechanism and its use, as we know, naloxone is an opioid receptor antagonist or a blocker. So it works by displacing opioids from their receptors, and it can reverse an overdose if it's given within a short time following overdose. And that's variable. So even if we don't know the time, but we strongly suspect that someone has overdosed related to an opioid, it's still worth giving it. Naloxone is one of those things like an EpiPen, where there's essentially no risk to giving the naloxone, but a lot of risk can be if it's not given in time. And so the worst that can happen is that you get someone whose overdose is reversed, and they can be pretty cranky. In my thinking, naloxone kits should be offered to every person who uses street opioids, but also to patients who are on higher dose prescription opioids. To patients who take opioids along with alcohol and benzodiazepines, because we know that those increase the risk of opioid-related sedation and overdose, and to family members and friends of those who use opioids, or to anyone. I have one in my purse, I have one in my car, I update them regularly to make sure that the expiry dates are good. There was a great tweet just the other day of a medical resident who was biking home and saw someone alongside the path who was passed out, popped out her naloxone kit, was able to call 911, administer naloxone at the same time, and rouse somebody. So it's important to remember, just to know that someone who's used fentanyl may need multiple doses, and that's okay. You usually wait 2 to 4 minutes after first dose and then can reverse it. For those who aren't comfortable, there are, as I said, nasal sprays. Although during COVID, I know that EMS providers and some of the overdose prevention site workers have been avoiding nasal sprays because of the risk of increased secretions. The other thing that I try to remember to counsel people is around what's called the Good Samaritan law, so that if you intervene with someone who has had an overdose and used naloxone, even perhaps if the person administering naloxone has drugs on them at the same time, there's an understanding currently that EMS and police are not about pressing charges for that person. The focus is really supposed to be on the individual who's overdosed and getting them to care. Naloxone kits are available through harm reduction services and through many, many pharmacies. They're free. They do not require a prescription. Anyone should be able to go in and ask for a naloxone kit. However, in my practice, what I do is write, please dispense naloxone kit on the bottom of a prescription, because I find that it's much more likely that someone actually leaves the pharmacy with a kit if I've specifically asked the pharmacist to dispense that. So as I think you're gathering, I'm all about looking at the balance between safety and harms. And that's what we'll be talking about with respect to opioid agonist therapy, or OAT. While there may be side effects and risks that are associated with treatment, and we shouldn't negate those at all, we need to prescribe safely and carefully. There's strong evidence that opioid agonist therapy is associated with a significant reduction in harms of opioid use, in fact, perhaps of other substance use, and in decreasing the risk of overdose overall, even in people who continue to use. And there are some really interesting studies showing that people on buprenorphine and methadone have lower risks of overdose even when they continue to use fentanyl, and that may be because of the baseline opioid tolerance that they've developed. So looking at the nitty-gritty of OAT, essentially all OAT is based on using long-acting opioids to assist patients in stabilizing their use and focusing on health and function. OAT works by essentially providing that long-acting opioid so that withdrawal symptoms are effectively managed. That helps to reduce cravings. That obviously helps to reduce someone's feeling of need to use opioids to help resolve or remove withdrawal symptoms and satisfy those cravings. And that results in a much safer profile for the person overall. You'll notice that I've talked about using OAT to help patients stabilize their use rather than necessarily moving towards abstinence. And that's because abstinence may be a really viable goal for some people, but isn't necessarily for everyone. But if we can help people to reduce their use in less intense ways, then we're still helping to keep them safe, hopefully, until they can move along that next level of the continuum for themselves. And of course, engaging people in care really is not only about reducing their opioid use, but it's also about helping to get them access to primary care services, to care for their mental health, to treatment for hepatitis C or HIV, to immunizations, to counseling services, housing, etc. So methadone is the medication most people are familiar with, and that's because it's been around the longest. It was originally used back in the 50s and 60s when it was recognized that its very long-acting nature could be effective in treating opioid use disorder. And there's a strong body of evidence around the benefits for methadone in helping to retain people in treatment, reducing morbidity and mortality from opioid use, reducing other substance use, and you can see the rest, including reducing the risks of hepatitis C and HIV and increasing treatment rates for hepatitis and HIV as well. So as I said, methadone, as all of the OAT approaches, is a long-acting mu opioid receptor agonist. And when it's titrated to the right dose, it can control withdrawal symptoms. We aim for 24 hours or a little bit more so that people don't feel withdrawal immediately as they hit 24 hours and feel that an imperative to get to their dose too quickly or else an urge to use. And as we've said, by suppressing withdrawal symptoms, it also helps to suppress cravings at all. So the goal is to find that balance where someone isn't feeling a high or a buzz, isn't feeling sedated at all, but essentially feels pretty normal. And the typical dose range where people get response is between 60 and 120 milligrams. There are a number of studies going back years that indicate that people at doses of 60 milligrams or above tend to do better. And better means remaining in treatment and also reducing their opioid use. A number of studies show that higher doses are associated with higher rates of retention. And we're certainly finding now in the days of fentanyl that because of the potency of fentanyl, people are requiring quite high doses of methadone in order to extinguish withdrawal symptoms and cravings, typically over 100 milligrams and often over 120 milligrams as well. So compared to other opioids, methadone has increased risks of toxicity and adverse events. And that's one of the limiting factors. And one of the factors that in the past was associated with Health Canada's requirement that prescribers obtain a specific exemption there's still an expectation, even though that Health Canada exemption has been lifted, that people who want to prescribe methadone do a particular course in Ontario that's offered through the Centre for Addiction and Mental Health, in order to familiarize themselves with the risks of methadone. And it's because it's cleared so slowly from the body, that's what the long half-life means, that there is an increased risk of overdose if the dose is increased too quickly, or if the dose is too high in combination with people who are taking other medications that can be sedating or suppress the respiratory drive. And so there's what's called that narrow therapeutic index, that small window between the dose that's helpful in a therapy or potentially toxic. And I would argue, as someone who's been prescribing methadone for many years now, that that window isn't quite as narrow as we might have thought, and yet we can still be surprised because there are some people who don't metabolize it well and who can experience severe side effects even at low doses. And there are particular concerns around people who have certain heart conditions associated with something called prolonged QT, which is an interval that can be measured on an electrocardiogram. And methadone can be associated with prolonging that QT and increasing the risk of some very dangerous heart arrhythmias, particularly when it's combined with other medications that also do the same thing. So all of this has led to some pretty strict guidelines around dose adjustments and take-home doses. People have to be on the same dose of methadone for a minimum of 3 days before their dose can be increased. The general expectation is that people attend a pharmacy for dosing every day for 2 months, until their dose is established, until it's been clear that they're not using illicit substances, and then they are able to take home 1 dose per week, and that's usually increased every month. So it's a pretty intense regimen. And that is part of what's led to a lot of people feeling like methadone is effectively liquid handcuffs. The need to attend a pharmacy and attend a clinic every day, you'll see on the next slide, I think, has made people feel like they're just chained to a methadone clinic. The other issue is the siloing of methadone within methadone clinics, which arose, again, partly because of these requirements for physicians to have specific exemptions to prescribe. And some of the monitoring, including urine drug testing and the frequency of visits, made it harder to incorporate methadone within a primary care setting. So all of that has really contributed to stigma, to people feeling like being on methadone just reinforces all of the stigma and negative impressions of people who use opioids as being just about the drugs, impressions that people are just addicted to their methadone and not doing any better. Unfortunately, without recognizing that some people do really well on methadone, are able to work, reunite their families, live full, productive, and healthy lives. But it's been hard for many people to move away from all of those negative associations. Thankfully, I think some of those things are changing, and I think buprenorphine has really helped to add another option of OAT, particularly appropriate for people with less intensive opioid use, but with benefits across really the spectrum. So comparing buprenorphine and methadone, buprenorphine is associated with a lower risk of overdose, with fewer drug interactions, and particularly with lower cardiac risks. We'll talk about why it has a lower risk of overdose and a lower risk of interactions and overdose with alcohol and benzodiazepines in terms of respiratory suppression and overdose. One of the nice things about buprenorphine compared to methadone is that we can often help people get to a stable and effective dose within just a few days or a week. Whereas with methadone, because of the requirements for 3 doses between dose increases, it can often take 4 to 6 weeks or longer to achieve a dose that's really feeling effective for someone. Another really useful thing about buprenorphine is that it's not subjected to the same stringent requirements around daily observed dosing at a pharmacy. So this really creates much more flexibility for people who are working or for people who want to travel. We can begin take-home doses much earlier, again, of course, using clinical judgment about when someone is safe to manage. And finally, even though there are some educational courses and everyone should be familiar with the medication that they're prescribing, there's not the requirement for a specific training program or designation in order to prescribe buprenorphine. So that's really broadened the accessibility into the primary care spectrum, and buprenorphine can be much more readily integrated within primary care. That's really key because we know that the burden of health issues is so great for many people with opioid use disorders. And when care is siloed within a clinic where they may be seeing a doctor frequently for OAT, but really not being provided with other health care, um, the health outcomes are really quite inferior. And so there was a great study indicating that people who do receive their OAT care within a primary care setting where they're being offered other healthcare interventions have much better outcomes in terms of diabetes, hypertension, and cancer-related screening. So how does buprenorphine really work? The next slide may look like it has a lot of very medical terms on it. We'll go through those briefly in the schematics in the next couple of slides. So it has this high affinity for the opioid receptor, a slow dissociation, which means it really sort of comes off those receptors slowly, so it's long acting. It's a partial agonist rather than a full agonist, and it has a ceiling effect. So let's look at those diagrams in order to understand that. The first one is a schematic showing you an opioid receptor and a full opioid agonist. So that could be morphine, for example, or heroin. And what we mean by a full opioid agonist is that it fits really neatly into that receptor and it fully satisfies it, for lack of a better term. I'll just mention that there is more than one type of opioid receptor. We typically talk about the mu opioid receptors because those are the most common and the most active within the brain. And those are the ones that most opioids are acting on. Buprenorphine actually acts on the mu and also on the kappa opioid receptors. So when the opioid attaches to the receptor, it stimulates dopamine and all kinds of other neurotransmitters that create feelings of well-being and also help to remove pain. But when the opioids are no longer around, they've been cleared out of the system, as you see in the next slide, that empty receptor is not happy and people get withdrawal-mediated pain and the whole range of other withdrawal symptoms: nausea, sweats, chills, restless legs, goosebumps, anxiety, agitation, runny nose, sneezing, diarrhea. It's quite a mess. So that's what happens with withdrawal. When we add buprenorphine to the mix, as you see when you look at the next slide, you'll see that the buprenorphine attaches to that opioid receptor, but it doesn't lock into it. It doesn't fill it quite as neatly. That's because it's what's called a partial agonist. So it still provides stimulation to the opioid receptor, but not the same full stimulation of the full agonist. So the release of the neurotransmitters, dopamine, etc., takes place, but not to the full extent that it does with the full agonist. But what you can also see, and I think you'll see this again in the next slide, is that it's blocking the other opioids from attaching. So it's attaching to the opioid receptor. It's giving enough stimulation to that receptor to take away withdrawal symptoms, but at the same time, it blocks other opioids. And so that not only results in a reduction in withdrawal symptoms, but it also means that the effects of other opioids aren't felt as intensely as when without the buprenorphine on board. And that helps to reduce someone's incentive to use because they're not getting an additional kick or euphoria from using. And so again, it helps people who are trying to reduce their use to feel like it's just not worth it after a certain point in time. The other property of buprenorphine that I mentioned is its ceiling effect, which you see on the next slide. And as opposed to other full opioid agonists like morphine, where the more you give, the more the effect increases, almost, if not exactly linearly. With buprenorphine, there's a ceiling or a maximum effect. So above 24 to 32 milligrams, no matter how much more you give, you don't get more opioid effect. And that's really helpful because it means that there's not an increase in the risk of respiratory depression. So respiratory depression is when people go to sleep, the part of the brain that's supposed to stimulate them to breathe gets suppressed and they don't wake up when their carbon dioxide levels go up, oxygen levels go down, and they can stop breathing in their sleep. And that's why buprenorphine is so much safer than methadone in terms of the overdose-related risk. How is buprenorphine formulated? Well, in Canada, it's combined in tablets with naloxone in a fixed ratio. So the fixed ratio, for example, in a 2 milligram tablet, that means there's 2 milligrams of buprenorphine with 0.5 milligrams of naloxone. The 8 milligram tablets have 8 milligrams of buprenorphine with 2 milligrams of naloxone, and so on. The 2 and 8 milligram tablets are the most commonly used versions because they are also covered on drug benefits. There are also 2 long-acting or depot formulations that we'll be talking about, an injectable and an implant, actually. In the States and in Europe, buprenorphine is available on its own without naloxone. That's called Subutex. That's not readily available here. One has to apply specifically to Health Canada for an exemption to access that. And that's really only necessary in very rare situations, such as where someone has a true allergy or intolerance to naloxone. We used to use Subutex in pregnancy. We no longer consider it necessary to change women from Suboxone, the buprenorphine naloxone combination, to Subutex during pregnancy. And in the States, it's also available as a film that we don't have in Canada. So as I mentioned, Suboxone is the trademark for the buprenorphine naloxone tablet. Why is naloxone included? This is something that comes up again and again. The naloxone that's included in the tablet doesn't do anything to the efficacy of the tablet. In fact, it's not absorbed into the body when someone takes their Suboxone sublingually. The naloxone was included specifically to deter people from injecting tablets. Because if you inject naloxone, it acts as that opioid blocker and causes very unpleasant withdrawal symptoms. So the idea was that including the naloxone would help to decrease the likelihood that people would misuse Suboxone tablets through injecting. That's mostly true, although it is still misused, including through injection in some parts of the country. But for the most part, it has helped to reduce the likelihood that Suboxone is misused. It's really important to remember that Suboxone tablets need to be taken sublingually. That means that they dissolve under the tongue. If the medication is swallowed, it actually is not active at all. Because of what's called first pass effect, it's not absorbed and effective. So it's really about the buprenorphine getting absorbed through the saliva into the mucosal membranes and directly into the bloodstream. The naloxone is not absorbed and has no effect. It doesn't increase or decrease the effect of the Suboxone tablet, nor does it make someone feel sick if they use opioids while they're on treatment. It is effectively not absorbed at all. So I hope that makes that clear overall. So looking ahead at some of the challenges around buprenorphine, we'll actually talk about them in reverse order. There are a few logistical issues around treatment initiation, around side effects, and then around retention in treatment. So if we look at retention in treatment, the primary issue really is that for some people who are injecting high potency opioids at high doses, it can be difficult to get the buprenorphine dose high enough to effectively control their withdrawal symptoms. And as I mentioned, there's that ceiling effect. So going above a certain level just doesn't help, and in fact may have some negative consequences as at very high levels, there may be some absorption of the naloxone. So as a result, buprenorphine is not always effective, and for some people has lower treatment retention rates. And that's why if we find that we've started and people are not responding well, we should really be prompt to recognize that and look at moving them over onto another form of OAT that may be more effective for them. The other thing is around side effects, and the side effects are particularly related to the sublingual dosing. Some people really dislike the taste. They find that it causes a lot of nausea. Some people get headaches as well. And dental issues are another factor that I don't think we recognized really early on. We always used to think about methadone being an issue in terms of dentition. And the question was it the methadone? Was it the tang? Was it the dry mouth or other medications and poor oral health or access to dental care? With buprenorphine, some people who have dry mouth need to really retain those tablets in their mouth for a long time. We usually say that it takes 5 to 10 minutes for the tablets to be fully dissolved. And we counsel people not to eat, drink, or talk while they've got the tablets in their mouth. But for some people, it can take quite a bit longer, especially if they have multiple tablets, to achieve the right dose, which is typically around 16 milligrams, but some people are on 2 and some people are on 24. And so there is some evidence that with the little sort of fragments of tablets in people's mouths, that it can cause some dental issues. And some people just frankly don't like the feeling, or don't like the feeling of the wearing on and off of the buprenorphine. The biggest challenge that historically people worried about with buprenorphine was around starting treatment, and that was because of something called precipitated withdrawal. And again, the schematic sort of shows it briefly. We talked about the fact that buprenorphine is a partial agonist, and it doesn't fully replace the effect of a full opioid agonist. So if someone still had an opioid on board, they used their morphine or their heroin just a few hours ago, then they take buprenorphine. Because buprenorphine has such a high affinity for the opioid receptor, it will knock off the other full opioid agonists and partially, but not fully, replace their effect. And that leads to a net opioid deficit and very intense withdrawal symptoms. So all of the withdrawal symptoms that you've heard about or that we've talked about, but sort of full on. And that is an extremely unpleasant feeling. And that fear of creating that led to some clinicians being fearful about prescribing because they wanted to make sure that they were going to be able to manage that. So our initial protocols for starting treatment really recommended that people be in withdrawal when they took their first dose of Suboxone. And so for short-acting opioids, that meant 6 to 12 hours. And for longer-acting opioids, we really encouraged people to be off of their opioids for 18 to 24 hours. We've moved towards some more novel initiation strategies, which you'll see on the next slide. Instead of requiring people to come into the clinic and withdraw, which was really unpleasant, we now do something called a home start, where we give people full instructions about what constitutes sufficient withdrawal to start their treatment, but they've got the medication at home with instructions so they don't have to arrive at a clinic in full withdrawal. And we also use a really interesting approach called microdosing, or the Bernese method. That was developed by Robert Hamig in Switzerland. And that approach uses buprenorphine starting at very, very small doses, like 0.5 of a milligram, while someone is still using their other opioid, and increasing the buprenorphine really gradually. And the way I describe it to people is in that way, the buprenorphine and the other opioids don't fight. The buprenorphine gets up to a level where there's enough sort of saturation of the receptors that we won't trigger that precipitated withdrawal or that conflict between the two. And once they get to that threshold, which is around 4 milligrams, then we can start to go up rapidly on the buprenorphine and cut down. And that can be used for people who are transitioning from prescription opioids, or other, including opioid agonist therapies like methadone, where we used to require people to be off methadone down to 30 milligrams and off for a full 3 days. It's made transitioning people from methadone to buprenorphine much, much easier, and we've had many successes using this. So looking at some of the long-acting formulations, as I mentioned, there's an injection and there's an implant. The advantages to the long-acting formulations, you can imagine, psychologically, freeing people from needing to take a dose every day or attend a pharmacy regularly can be really impactful for people. They're also really useful for people who were missing doses frequently, because once the injection is in, it's in, or once the implant is in, and they achieve a much more stable blood level. So there's much less up and down, return to withdrawal and to the urge to use overall. And they're also appropriate for people who are not able to tolerate the sublingual preparations. So the injection, I think, is what we're talking about on the next slide here. It shows a little bit of, this actually came from the, I think, a Sublocade monograph, so I apologize, it's brand specific. But this shows the difference between taking sublingual buprenorphine daily and the ups and downs that go along with the timing of the dose versus the blood levels that can be achieved after an injectable from the depot. So you can imagine that someone just might feel much more level overall. And in fact, there are studies that show that the overall level with Sublocade, the injectable form, is higher than with doses of the sublingual buprenorphine, which again may be helpful in people who are using higher potency opioids and need a higher blood level of buprenorphine in order to control their withdrawal symptoms. So looking at the next slide, the Sublocade, just really briefly, comes in 2 doses. It's meant for people who are in doses of 8 milligrams sublingual or more. And you can't start someone directly on Sublocade. They need to be stabilized first on the sublingual version of buprenorphine for a minimum of a week. It's not suitable for people in pregnancy. It's not the buprenorphine that's the issue. It's the excipient that creates that depot formulation. And the approach is 2 doses, 28 days apart, of the 300 milligram dose. And that helps to build sufficient blood levels to maintain stability. And after that, the usual dose is 100 milligrams monthly, although there are a small number of people who do experience withdrawal and seem to benefit from 300 milligrams. Those studies did not show that that was a significant benefit. It needs to be given by someone, a healthcare provider, who's taken a very brief online course in giving the injection. It causes sometimes some redness and irritation around the injection site. And interestingly, it just in this last week, we've heard that there is a shortage. I guess there's been a good job amongst our educational networks of letting people know about Sublocade, and it's been really well received. And we're hoping that that shortage will be addressed quickly because there are people who will be coming up to their next doses. Next slide, please. So this just is an indication of what happens with the depot. It's a sub-Q injection into the abdomen, and it forms quite a sort of palpable thick ball. It's really a viscous injection. You have to push with your thumb when you're doing it. And then the medication is absorbed very gradually over the course of the month. There are good studies that show that buprenorphine levels are still adequate up to 2 weeks beyond the 28 days. So if people miss that 28-day for their injection window, that's okay. We don't have to restart them. If they've gone a lot longer, we might have to get them back onto sublingual buprenorphine to get them ready. And the implant, which is called probufene, is a little bit different. Rather than a monthly injection, that's a series of little flexible rods which are implanted into the upper inner arm, much like the old Norplant for contraception. This is intended for people who are on stable doses of 8 milligrams or less, and who would benefit from long-term treatment without needing to attend a pharmacy. The implants are effective for 6 months. So this would be someone who's really stabilized, who knows that buprenorphine is working well for them, but would benefit from not needing to attend a pharmacy. So we could imagine people who, travel often from work, who have already attained stability, The other interesting thing about both of these formulations is that because the blood levels are so stable and they decrease very, very slowly at the end of the lifespan of the implant or the injectable, there's much less wearing off. And that might also be helpful for people who are looking at tapering their buprenorphine use, because it avoids the sort of more sudden or intense withdrawal that happens when someone is on daily dosing, and can help to just kind of wean or taper off nicely and gradually overall. So that's not a formally studied or evidence-based recommendation yet, but it's certainly one of the things that we're looking at. Really briefly, I just want to mention slow-release oral morphine. It's definitely our third-line treatment, and that's intended for people who have not stabilized, that's on the next slide, on methadone or on buprenorphine. Just to go back to this slide for a moment, thank you. As I mentioned, I think buprenorphine can be really effectively incorporated in primary care, particularly for people who've already been stabilized by an addictions provider and are on maintenance dose, those who don't have complex polysubstance use, and especially for people who really would benefit from co-management in one setting of their medical and mental health issues. Primary care is an optimal setting, and there are lots of ways of looking at including buprenorphine care, either sort of co-managed with an addictions prescriber or initiated in primary care directly. What I don't think fits so well in primary care is slow-release oral morphine. That is definitely third line, and that's using Cadian capsules, often at doses that are quite high, up to hundreds of milligrams. So it seems to sort of run against the recommendations for opioid use in chronic non-cancer pain, where we've been working so hard at getting doses down to 90 milligrams or below. However, these doses can be effective in people who've been using high-dose fentanyl, and we're looking at doses that are anywhere from 150 up to 500 and 600 milligrams of morphine a day. That's one of the reasons that it typically is dispensed daily almost forever until someone has really achieved major stability. It's really important for the Cadian or the SRAM capsules to be opened and sprinkled onto something and have observed ingestion at the pharmacy, because you can imagine that's a very hefty dose of opioid if it were diverted outside of the pharmacy. But it is safer than methadone in patients who have prolonged QT syndrome. You may start to see people being co-prescribed methadone and morphine in order to try to really help balance their side effects and their symptoms overall. And then some other innovations, injectable opioid agonist therapy. So that's not happening in Ontario yet, although there are various applications. The guidelines have come out of BC. The original clinic and study used injectable heroin, diacetylmorphine. More recently, we've been using injectable hydromorphone in liquid formulations. There are lots of barriers to getting those clinics up and running here in Ontario, but I think you'll be seeing more of them over the next few years. I would still consider that to be really along the spectrum of treatment and harm reduction. It's been shown to be quite effective in terms of improving healthcare use, social function, and improving people's stability overall, although it's quite binding to have to go to a clinic every single day. And then lastly, there's an initiative you may be hearing about called Safe Supply or Safer Supply. And that's, I would consider true harm reduction rather than treatment. That really speaks to the barrier around access to good, or barriers to good quality opioid agonist therapy and to injectable opioid agonist therapy. And that involves physicians prescribing hydromorphone tablets, often at quite high doses, for people to take home and inject. Needless to say, tablets are not meant for injection, and there are many issues around people taking tablets home and injecting in unsupervised fashions. But this is really sort of a desperate reaction to the fact that the street supply is so toxic. The overdose rates are so high, and physicians really trying to use what's available to them in their toolboxes. And we often say, there are big systems that we can't change. We've got our prescription pads. So you may see some of that coming in certain areas across the province and country. Hopefully with research to follow, because right now it's really unclear about the safety benefits versus other forms of treatment. And my 2 cents worth is that I'm strongly in favor of evidence-based opioid agonist therapy, and not in favor of safe supply hydromorphone prescribing as it's being prescribed right now, although I really recognize where it's coming from with respect to the intentions of the providers. So I think in the interests of time, I'll summarize really briefly these next slides to just suggest that up to 75% of individuals with substance use disorders have experienced trauma. There's a huge prevalence of trauma, including adverse childhood experiences, and that literature is fascinating. I'm hoping that most of you are familiar with it. Major rates of PTSD, mood disorders, and anxiety disorders, and Health Quality Ontario standards, I think, make it quite clear we do not and should not be expecting or requiring someone's substance use to stabilize or for them to be abstinent before we can treat their mental health disorders. In fact, that's counterproductive. We need to focus often first on stabilizing the substance use. So in the case of someone who's using opioid use disorder, initiating buprenorphine or methadone. And if their mood and anxiety disorders persist when withdrawal and use are stabilizing, we should move on to initiating treatment for their mental health disorders. And by treatment, I don't mean only pharmacotherapy, of course, but the full spectrum, and work on treating those concurrently, because there is good and emerging evidence that concurrent treatment results in better outcomes for both. So if we look at summarizing, just to jump ahead in the interests of time, thank you so much for joining me. I hope that what you come away from today with is a recognition that opioid agonist therapy is first-line treatment, that people do best when OAT is combined with psychosocial supports and harm reduction strategies, that buprenorphine is a very viable medication to offer people to incorporate within primary care because of its improved safety profile. But we need to really be flexible and look at where people are when they come to us seeking care, to continue to consider the continuum of harm reduction and treatment and the continuum of which types of medications are going to work best for them, and to be mindful always about where that person is at and trying to address both their mental health and their substance use disorders. And I guess the last thing I want to say, because it's not mentioned on any other slides, is the importance of recognizing the overlap of substance use disorders and focusing not only on one substance, and that might be very obvious, but I've certainly in my own practice realized sometimes belatedly that while I thought I was doing great managing someone's opioid use disorder, they were drinking themselves into dire circumstances. And so there are people who have issues with only one substance, but of course there are those who have issues with multiples, and we need to look at that entire complex overall and think about the improvements to their health and well-being when we're doing a better job of recognizing and improving their health. So thank you so much. I appreciate your time today. There were some questions that were prepared, and I'm not entirely sure if everyone has time to stay on. I will go through them really quickly, and appreciate that everyone has stayed on for this entire duration. So the first is many people with opioid use disorder also have chronic pain, and that's very true. In fact, having chronic pain and an opioid prescription is a risk factor for opioid use disorder. Can buprenorphine be used to treat pain, or is it just for treating opioid use disorder? So the official indication for the Suboxone tablets and the buprenorphine naloxone tablets is for treating opioid use disorder. However, buprenorphine also comes as the Butrans patch, a buprenorphine patch, which is indicated for pain. And I would argue that it's the same molecule. I've had a number of situations now where people who were experiencing risks or were at risk from the adverse effects of other opioids were effectively transitioned to buprenorphine naloxone for the treatment of pain without having any indication of opioid use disorder. So I think it's something that you will see more of overall. It still requires that finessing around starting that I mentioned, and this is a perfect role for microdosing as an opportunity to start. And there are various microdosing protocols. The one that I use most is available on the Medify website, which I think is at the final end of our slides. Another question I think had to do with how long people should be on methadone, and should people be coming off it at a certain point in time. I think that goes back to that sort of notion of liquid handcuffs, that once you're on methadone, you're on it forever and ever. And certainly there are people who are on OAT for many, many years. I would say I've harped on this harm reduction concept. But if we think about opioid agonist therapy as a means to help people achieve their goals around their health, their family, social function, work, and everything else, we should look at whether the treatment is helping them to achieve that. And for some people, tapering is reasonable when they've had a good period of abstinence, their physical and mental health issues are in good shape, their supports are good, they can begin a slow and gradual taper. But for some people, the benefit of having that opioid stabilizer is really evident long term. So I think it speaks to the need to revisit treatment every so often, encourage people to look at what they're doing for their overall health rather than just taking their medication. I find that makes a really big difference. And think about what all of this is for, right? What's their purpose in terms of engaging with the rest of the issues in their lives. And then I find that many people are ready to taper, but it has to be very patient-centered, is what I would say. And then finally, there was a question about whether buprenorphine is safer than methadone in pregnancy. Both methadone and buprenorphine are now considered to be first-line therapy in pregnancy. They both can be associated with a withdrawal syndrome that's called neonatal abstinence syndrome or neonatal withdrawal syndrome. And that's because babies exposed to chronic levels of opioids in utero do experience changes when they're born and they're not exposed to that. So there was a great study that showed that babies born to mothers on buprenorphine required lower doses of medication to treat their symptoms, but they are not necessarily without withdrawal symptoms overall. Interestingly, it doesn't seem to be the dose of buprenorphine or of methadone that's associated with the likelihood of that neonatal withdrawal syndrome. There are lots of other factors. Maternal smoking is actually a really big one. In every case, it comes down to needing to consider the risks and the benefits. And so for a mom who might be using opioids in much higher risk ways, certainly the advantages, in my mind, of treatment and true engagement with healthcare, whether it's with methadone or buprenorphine, far outweigh the risks. And pregnancy can be a great time actually to engage people in treatment and looking after themselves in really effective ways. So thank you again. I will draw your attention finally to two resources that I'm connected with. The Opioids Clinical Primer, as I mentioned, is a set of online courses, 6 in total. This was funded by the Ministry of Health, and they're divided into courses on managing opioid use disorder as well as managing chronic pain. They're available on the MAC Health website. They're free, they're evidence-based, they're accredited, they are aimed at prescribers, so physicians and nurse practitioners, but they're useful to anyone wanting to increase their knowledge in these areas. So I would be happy if you looked at those. And then lastly, Medify, which is a provincial organization housed at Women's College, providing guidance to clinicians across the province through education, mentorship around treating people with substance use disorders. There's a wealth of resources there. The microdosing protocols that I mentioned are there, along with many other tools for providers, and not just physicians, but counselors as well. And our Medify conference is coming up September 25th. It's a virtual conference addressing some really key issues in current treatment of people with substance use disorders, including incorporating anti-oppression practices into our work, and the impact of COVID on the care for people with OAT. Thank you so much.
Thank you for joining us today. We will follow up with a recording of the webinar, along with your certificate of completion early next week. Thank you to our sponsor, Shoppers Drug Mart. Shoppers Drug Mart recognizes that Canada is facing an opioid crisis which continues to cause significant harm to many Canadians. Building on the existing efforts taken by their more than 1,300 pharmacy teams across the country, Shoppers Drug Mart is committed to ensure broad access to treatment for opioid dependence, alternate options for pain management, and naloxone through our pharmacies. Their pharmacy team provide treatment in a respectful, supportive environment with utmost confidentiality. Visit shoppersdrugmart.ca/ODT to learn more. Thank you.